Hello everyone, it is that time of year again for our annual Bloodborne Pathogens update. This is Stephanie Mossy. I will be narrating this PowerPoint, so we won't delay any further. We'll jump right into our 2015 update. This is OSHA 1910.1030 standards that we will be reviewing. We've got some objectives here, some information we're going to go over. Like we did last year, if you see slides with pink at the top, that means it's new or updated information. A lot of the slides will be blue, meaning that it's information for us to review again that we need to every year. So objectives here, we're going to look at disease information. What are the training responsibilities of the department? We're going to give you the required refresher training, and we're going to look at some department compliance issues if there are any, give you some information about PPE, talk about declination forms and why we use them, give you some information about the new flu vaccines available, and this year some new information we've got to talk about are a few outbreaks that occurred in 2014. So what are bloodborne pathogens? They are viruses, bacteria, and other microorganisms that we know about. We know many of them by name. They can be carried in the bloodstream. They can be transmitted through other potentially infectious materials, and they are known to cause disease, which is why we keep bringing them up to do training on them every year. There's over 20 different ones out there. We've got some that are of more concern than others. The ones listed here are 2 forms of hepatitis and HIV. Let's start out with disease numbers on a national level. We have on the left side the numbers from 2013. On the right side we have numbers for 2014. As you can see, we have a decrease in the overall new cases that have occurred. Hepatitis B and tuberculosis in general have decreased, but if you look at the ones that have increased, hepatitis C, syphilis, and pertussis are ones that have increased, and we'll talk a little bit more in depth about those. When we look at South Carolina specifically, generally South Carolina DHEC will give out information on our numbers on a statewide level and on a county level. That information is not published on their website yet, so the numbers at the top, if you look at hepatitis B, 35 new cases in South Carolina, hepatitis C, 138 new cases, and syphilis, 248 new cases. These numbers I got from Catherine West at our OSHA Bloodborne update in May in Charleston. The numbers that South Carolina did have was that we had 79 new cases for tuberculosis. Those numbers decreased from last year where we had 112 new cases, and of those 79 for 2014, 4 of them came from Horry County. Looking at Horry County Fire Rescue, when we're looking at our total exposures, last year's numbers are listed there for 2013, bloodborne exposures, other exposures, and airborne exposures totaling 18 in 2013. For 2014, we had 5 total bloodborne exposures, and we kind of broke them down based on what their criteria was. We had 0 other contact exposures and 0 airborne, so our total for 2014 was 5, which was much better than 2013. We heard about this last year as well, a change in terminology. Certain diseases used to be called hospital-acquired infections. Now they're calling them healthcare-associated infections. So patients who come into hospital facilities or other healthcare facilities and they don't have some kind of infectious disease and they end up acquiring one while they're there. Generally, hospitals have been the ones that have been looked at for these, and insurance does not reimburse the care for those infectious diseases that patients contracted while at their facility. It has changed now to healthcare associated because the change is that they are no longer focusing on hospitals. They are now looking at EMS agencies, nursing homes, dialysis centers, and other facilities where patients are being treated as well. Again, to review a contamination versus an exposure. Contamination, its definition here, the presence or the reasonably anticipated presence of blood or other potentially infectious materials on an item or a surface. An exposure, the definition, a specific eye, mouth, other mucous membrane, non-intact skin, or parenteral contact with blood or other potentially infectious material that results from the performance of an employee's duties. So, did it get in a mucous membrane? Did it get in non-intact skin, or did it puncture now and get into the bloodstream that way? So contamination, it's just on a surface. Exposure, it actually enters the body in one way or another. Ryan White information. We heard about this last year as well. This gives a list of potentially life-threatening infectious diseases to which emergency response employees may be exposed. So these are the list of diseases that we do review every year and give you additional information on, and these are reportable diseases as well. This law also gives standards for vaccines and immunizations and training responsibilities of the department. When we look at the list of reportable diseases under Ryan White, we'll start with bloodborne. We have HIV, hepatitis B and C, vaccinovirus, rabies, cutaneous anthrax, and viral hemorrhagic fevers. Airborne diseases, we have measles, chickenpox, and tuberculosis, and we will discuss later in this PowerPoint on the measles outbreak that we saw in 2014. Droplet and meningitis, diphtheria, pertussis, mumps, plague, rubella, SARS, and novel influenza A viruses, which are new and different ones, not necessarily the seasonal flu, but new flus that come about like when the H1N1 came out. We're going to talk about different types of precautions as well, contact precautions and how to protect yourself, as well as airborne and droplet precautions, and what types of PPE we need to wear. For contact precautions, we are going to use contact precautions for patients with certain illnesses or diseases. These are listed on the left. If they have MRSA or VRE or multi-drug resistant organisms, we are going to make sure we have contact precautions. Norovirus, head lice, skin and wound infections. Ebola has made the list this year. C. diff is on there as well. If patients have draining wounds or uncontrolled secretions or bleeding, we want to make sure that we are covered under contact precautions. PPE usage for contact precautions, we want to make sure that we have gloves. Sometimes double gloving is appropriate as well. And a gown, especially if we anticipate that we're going to have a large amount of potentially fluid that we may come in contact with, such as blood or secretions, or if we're going to have some pretty substantial contact with the patient and or the environment that they are in. We definitely want to make sure that we have good hand hygiene and that we clean and disinfect our reusable equipment like our glucose monitors, our cardiac monitor, our blood pressure cuff, stethoscope, pen light, equipment such as those. Airborne precautions, specifically for the airborne diseases, we saw measles, tuberculosis, and chickenpox. With chickenpox, we especially want to take airborne precautions until the lesions have crusted over. For PPE usage, airborne requires standard precautions as well as a surgical mask. A surgical mask is completely appropriate for fire and EMS use, and this is good as far as a 6-foot distance. If there is spray of respiratory fluids that we anticipate, we've got our standard precautions in place. We can add a gown, an eye protection, and face shield to that as well. Make sure we're also having good hand hygiene and disinfecting our equipment like we would with the contact precautions after patient use. For droplet, specific conditions, any kind of respiratory virus, and we have a few listed here, but anything respiratory, make sure we've got a mask either on the patient or on ourselves. Pertussis, mumps, meningitis, and Ebola has made the list this year as well for droplet precautions. Just like airborne, we want to have standard precautions in place. A surgical mask is appropriate to wear, and droplet, we're looking at a 3-foot distance. Again, the same as with airway. Precautions, if we anticipate a spray of respiratory fluids, we want to make sure that we have our standard precautions in place and that we have some extra protection from eyewear and a face shield. Hand hygiene and disinfect that equipment again. So let's start getting into some of the conditions. We're going to start with the bloodborne diseases. Our first one is HIV. HIV is the virus that leads to AIDS. To date, this number has gone up this year. Now there are 58 healthcare workers that have documented occupationally acquired HIV infections. We continue to have 0 of them that were fire or EMS personnel. 49 of the 58 were sharps related. And the CDC made a statement saying that more than 90% of these occupational acquired infections did have non-occupational risk factors that were reported for acquiring their infection. The incubation period for HIV is 1 to 3 months. Anyone who has HIV is considered potentially infectious from the onset of them contracting it throughout their life. And we'll talk about this a little bit more in depth. There is no cure for HIV or AIDS, but there are some really good medication treatments for them. Everyone is susceptible to it, and there currently are no vaccines available. Routes of transmission are listed here. The primary route is through sexual contact. Secondary route is through sharing IV drug needles and syringes. It can also be passed from mom to baby through blood transfusions. That generally was before they began testing for things such as HIV in donated blood. And occupationally, needle stick injury is generally the route that we're concerned with. When you look at the risk of transmission for needle stick, there is a 0.3% chance of contracting HIV through a needle stick injury occupationally. A splash or spray to the mucous membranes is an even smaller risk at 0.09%. Non-intact skin is less than that of mucous membrane exposure, so very, very rare chance of contracting HIV. The biggest risk factors for actually acquiring HIV occupationally is if the individual sustains a deep needle stick injury, like you let go of the syringe and the needle is standing straight up in your arm or in whatever muscle it was in. Sustaining an injury with a device which is visibly contaminated with blood. Being injured with a needle that has been placed directly into the source patient's artery or vein, right at the source. And if the source patient is in terminal stages of AIDS, or if they have a high viral load, and generally that load you have to have more than 1,500 circulating virus per 1 milliliter of blood. So there's got to be a large amount circulating in order for that person to actually be able to transmit this occupationally. Updated information. Since 1999, there has been 1 new occupationally acquired HIV case. That number changed back in 2013. We have reports of that. It's new this year in our update. So 1 new case since 1999. HIV is now considered a chronic disease. People are living with this now 50 years longer post-diagnosis than they have been in the past. And 96% of patients taking and responding to the AIDS cocktail, the 3 mix of drugs, are actually unable to transmit the disease. The AIDS cocktail is the 3 drugs listed below. I'm not even going to try to pronounce them because that would be amusement in itself. But essentially within 48 weeks on this mix of medications, the individuals have no HIV virus in their blood. They're not able to transmit it to others. They are not cured from it, but they cannot transmit it to others. There are some changes to post-exposure testing as well. If you acquire an exposure at work and the source patient is tested, if their rapid HIV test is negative, then no further testing is needed. We don't need to test the employee because the patient is negative for HIV. Rapid testing of the source patient to determine whether or not they are negative or positive will help prevent employees from being prescribed toxic medications. These medications can make you very, very sick, even for a short amount of time on them. So if the source patient is negative, there's no reason to start employees on these medications. CDC guidelines were updated in September of 2013 for post-exposure testing. If the source patient is HIV positive and has viral load, then we will do baseline testing for the employee. We will do 6-week post-exposure testing and 4-month post-exposure rapid HIV test. There are a few rapid HIV tests out there. They are listed here in the bottom right side of the screen. Moving on to the hepatitis B virus. It has an incubation period of anywhere from 60 to 150 days with an average of 90. The person is infectious if they test for positive for the antigen listed here. Mainly the people who are susceptible are those who have never had the hepatitis B vaccine. Symptoms, if they have any, are fever, muscle aches, fatigue, and jaundice. However, half of the people, or sometimes 60% of them, don't even know that they do have the virus. They may not have signs and symptoms. So anytime you do acquire an exposure, it is very important that you report it because some patients may not know some of the diseases that they have. Routes of transmission for hepatitis B: blood-to-blood contact, sexual contact, and indirect contact with a contaminated object. Hepatitis B can live on the surface of objects. So this is important to know. The patient that had a significant amount of blood loss that got on the railings of your stretcher or on your reusable equipment, please make sure you are deconning these appropriately because they are potentially infectious. Risk of transmission for hepatitis B: a needle stick injury does have a significant risk of transmission, 6 to 30%. That's a lot more than HIV, which was 0.3%. So if the source blood is infected with hepatitis B, there is a 6 to 30% risk of transmission. Risk of transmission also includes direct or indirect contact with non-intact skin or a mucous membrane, so make sure you are reporting exposures. The good news is, with a risk of transmission as high as 30%, there is a vaccine for this. The hepatitis B vaccine is required for all employees who are at risk of exposure. It must be made available to all employees. It must be free of charge for them, and it must be given at a reasonable time and or place. Generally, this comes into play with new hires. During the new hire process, this is assessed to see if individuals have or have not had the vaccine, and if they have not, if they would like to begin the series at new hire. The vaccine must be performed by a licensed healthcare professional, and there are some mild symptoms that may come along with it, such as soreness at the injection site or a low-grade fever. It is given in 3 different doses. There are specific time frames that are listed here, and when the whole series is done, about 1 to 2 months after the last dose, there will be a test for immunity. A titer will be drawn. If an individual does not respond to the initial 3-dose series, they will be revaccinated. As far as effectiveness of the hepatitis B vaccine, 90% of the people who have the hepatitis B vaccine do gain immunity after completing all 3 doses. In the first dose alone, it can provide 30 to 55% protection. The second dose is about 75% protection, and after the 3rd dose to complete the series, there's about a 90% protection rate from hepatitis B. Since 1983, we have seen a 95% reduction in the number of healthcare workers infected with hepatitis B virus, largely due to the vaccine. Some new information here. All trainees must have 3 doses of the hepatitis B vaccine before being placed at risk. These are standards set by the CDC. The 3-shot series should be completed before they can be involved in patient care. A statement here from the CDC says, healthcare professional trainees should complete the series before the potential for exposure with blood or body fluids, when possible, as higher risk has been reported during professional training. I also gave a link here to give additional information. New personnel who cannot provide documentation of immunity, it's considered that they have not been vaccinated and will restart a 3-shot series. Again, a titer will be drawn 1 to 2 months after the completion. Hepatitis C, incubation period of 6 to 9 weeks. 70 to 85% of the people infected with hepatitis C are infectious for life. This does lead to chronic liver disease and liver cancer. Symptoms are listed below. They range from fever to muscle ache, fatigue, loss of appetite, jaundice, dark urine, and whitish stools. Currently, there is no vaccine available for hepatitis C. 80% of the people infected with hepatitis C don't have any typical signs or symptoms of hepatitis. So again, reporting an exposure is very important. Routes of transmission are listed below: IV drug use, blood-to-blood contact, blood transfusions, needle stick injury, sexual contact, and sharing personal items contaminated with infectious blood, such as razors or toothbrushes. If the person has tattoos or body piercings, they pose as an increasing risk factor, and they add an extra 15 to 30% risk to that. Risk of transmission for needle stick is 1.8%. Mucous membranes and non-intact skin are both very rare. So hepatitis C, small risk compared to hepatitis B. In recent years, we have seen the rate of hepatitis C increase. We have seen some isolated outbreaks in places such as free dental clinics and other dental practices, dialysis centers, and ambulatory care centers, and most of the reasons for this was improper infection control practices. Since 2001, there have been more than 157,000 people who were called back for testing on HIV, hepatitis B, or hepatitis C because there was some form of non-compliance with infection control practices. The CDC does recommend that anyone born between 1945 and 1965 have a one-time screening for hepatitis C using a rapid test. There are a few different rapid tests. The one here is OraQuick. You're looking at a 20-minute time frame with a 99.8% accuracy. It does screen for a few different genotypes of hepatitis C. If there is a positive rapid test, it does not mean that the person is currently infected with hepatitis C. But if the rapid test is positive, they will do a viral load blood test to confirm the positive results. In the event of an exposure where the source patient is hepatitis C positive, post-exposure care is a blood test 2 weeks after the exposure. If the post-exposure testing shows that the employee has contracted hepatitis C and they are positive, treatment will begin and is generally an 8 to 12 week treatment. The first one, Teleprevir, actually cured 75 to 79% of the patients taking this in 24 weeks of treatment. There's another medication called Sovaldi. This is for a few different genotypes of hepatitis C. An amazing thing here, it is helping to cure 80 to 95% of the patients taking this medication, and it's doing it in less time than other medications on the market. It is a once-a-day pill. It is given in conjunction with another medication. It costs about $1,000 per pill and has a treatment time frame of 12 to 24 weeks. So if you look at $1,000 a day for 12 to 24 weeks, you're looking at about $84,000 to $168,000 for this medication. Now, yes, that is a lot of money, but when you look at the cost of liver transplant, post-transplant medications, medications to treat liver failure, hospital visits for liver failure, the savings will far outweigh anything else that's going to come along with liver failure for this patient and the pricing that comes along with that as well. Next is syphilis. Generally, we know syphilis as a sexually transmitted disease or illness, but it is grouped under bloodborne pathogens because it's also a bloodborne disease caused by bacteria. Primarily, it is transmitted by sexual contact, but it can also be bloodborne contact as well. It is a routine part of the post-exposure follow-up, especially with patients who are HIV positive and hepatitis C positive. For the sexual transmission of it, Signs and symptoms include primary lesions that can appear 3 weeks after exposure, a rash on the soles of the feet and the palms of the hands that can occur 3 to 4 weeks later, and it can progress into latent stages if it's not treated. Generally, treatment is an antibiotic such as penicillin or doxycycline, and it is a part of point-of-care testing. Some updated information on syphilis. There's more testing guidelines in the CDC's 2010 version of the Sexually Transmitted Disease Guidelines, and I gave a link here for additional information. There are some groups at risk. They've changed some of the names, and they've also added a group as well. Groups at risk: inmates, people who are HIV positive, men who have sex with men, injection drug partners. Sex workers is a terminology change. They removed the words prostitutes and changed it with this. And the group that has been added is senior communities, because we are seeing a larger number of syphilis cases in senior communities and nursing homes. Some more updated information on syphilis. The CDC had a plan in place to remove syphilis from the United States by 2015. But that has not occurred, so they have pushed that back to 2020. I also gave you a link here if you'd like additional information on their goals and their plan to eradicate that. There are some states that do have plans in place to eliminate syphilis. They are listed here. South Carolina is one of them. And when we look at the map of the United States, we've got the highest cases of syphilis for 2014. Alaska is new to the list this year. California was on the list last year. Pennsylvania is new to the list this year as well. And we saw Texas, Florida, and New York last year also. Point-of-care testing is a current standard of care. This can be performed in the emergency room. It can also be at clinics, and some EMS agencies are using this as well. It does help to improve patient outcomes, and it helps to decrease any unnecessary or inappropriate antibiotic use because you're able to get answers very quickly and at the bedside. It is a laboratory testing that takes place where the patient is located, so you're not sending things back and forth to the lab. You use a small amount of blood, it's done right at the bedside, and you get answers very quickly. It does test for several different things. These are some diseases in particular, especially bloodborne ones, and new to the list this year, point-of-care testing also tests for STDs. Moving on to airborne. The first one is tuberculosis. This is caused by a bacteria, not a virus. Symptoms of TB: a persistent cough that lasts longer than 3 weeks. It can be either productive or non-productive. Weight loss: night sweats is a very classic one. Swollen lymph nodes, hoarseness, and chest pain. When you are transporting a patient who is suspected to have TB or who is confirmed to have TB, place a mask on the patient. A surgical mask is appropriate. Use the exhaust system and open the windows. There was also a goal to eliminate TB worldwide by 2015, and that goal now has been moved to 2020. Looking at the risk assessment, risk is generally classified by the amount of time spent with the infected individual, the ventilation that was present at the time of exposure, whether you were outside in open air or if you were in a small confined space, and if any prevention measures were utilized, such as wearing a mask and safety glasses. The CDC does have a TB risk assessment. It is based on the number of active, untreated TB patients that were transported in the last year. So they classify low risk as transporting less than 3 of the patients that fit that criteria. Medium risk is transporting more than 3 in the last year. Horry County Fire Rescue in 2013 had 1 tuberculosis exposure. In 2014, we had 0. So we are considered low risk again. And since we are a low risk department, there will be no annual TB testing done this year again, per CDC recommendations. Multi-drug resistant tuberculosis, there are a few kinds. They are generally from foreign-born people that bring them into the United States. You can see the cases from 2010 through 2013 on the left side. On the right side, you can see through 2014. The good news to this is that both cases are treatable. There's now a new, shorter course of treatment for tuberculosis. There's a 12-dose regimen. This occurs after a person tests positive for the first time. Treatment is generally 12 weeks now instead of 6 to 9 months. Monthly liver function testing is needed while taking these medications because it does affect the liver very heavily. No alcohol while taking these medications because the medications can be liver toxic, so we don't want to add any additional work to the liver. Some updated information about tuberculosis. There has been a national shortage of the TB testing solution for a few years now. So there are 2 blood tests for TB testing. They are both FDA approved and reasonably priced. They are stated to be more accurate than a skin test, and results generally take about 2 days to come in. The blood tests can be used for the new higher testing process instead of the 2-step skin test. We have also seen a national and global reduction in the number of new cases of tuberculosis due to directly observed therapy. Directly observed therapy is a process that makes sure that patients are taking their medications as prescribed. Patients will come to a facility where there is a healthcare provider or designated individual there to hand out the medications. They give the patient the medication and they physically watch them swallow the medication for every dose that is prescribed to them. Many health departments use this as a standard of care, and because they are monitoring and making sure patients are taking medications as prescribed, we have seen an overall decrease in new tuberculosis cases. This procedure is used for many other conditions as well. Droplet. The first one is pertussis or whooping cough. This is highly contagious and transmission is face-to-face contact within 3 feet of someone who is symptomatic. It can cause serious and sometimes life-threatening complications in young children and infants. Signs and symptoms usually appear within 7 to 10 days of the initial exposure, and they include items listed below, such as fever, that classic whooping on inspiration, and spasms as a result of severe coughing. Prevention for this includes a vaccination, a booster vaccine for adults, and placing a surgical mask on the patient or on yourself if the patient cannot tolerate. Pertussis is generally treated with antibiotics, such as a 2-week-long erythromycin treatment. There are complications of pertussis, and they can be severe. In infants, about half of the infants who contract pertussis end up being hospitalized. The younger the infant is, the more likely they will have a hospitalization. About 23% of infants who acquire pertussis also get pneumonia. 1 or 2 in every 100 can have convulsions. 2/3 of them can have apnea, and 1 in 300 can have swelling of their brain. And it is possible for death in 1 or 2 out of every 100. For teens and adults, generally the complications overall are less severe, especially if they've received the vaccine. But the most common complications are as a result of their continuous coughing, such as a fractured rib. About 5% of teens are hospitalized after contracting pertussis. About 2% of teens who get pertussis get pneumonia in addition, so that's very different than young infants and children. Most common complications in adults include weight loss, loss of bladder control, passing out, or rib fractures from severe coughing. Many of the infants who do contract pertussis get it from their siblings, their parents, or caregivers. The CDC says that the best way to prevent pertussis in all age groups is getting the vaccine. Make sure that you are staying up to date on vaccines and that you have gotten a booster if necessary. Rubella or German measles. This is by face-to-face transmission. Incubation is about 14 days. Signs and symptoms: low-grade fever, rash, headache, upper respiratory systems. There is a vaccine for this. It is the MMR. This is a live vaccine, so it is not to be given to pregnant women. For patients who are positive for rubella, a surgical mask on the patient is appropriate. If they cannot tolerate it, you can wear a mask on yourself. Getting into seasonal flu and flu shots. The CDC does have a flu vaccine program. They recommend the flu vaccine for all healthcare workers who are involved in direct patient care. Employers must offer a flu shot, and employees who decline, they need to sign a declination form. Overall, EMS participation in annual flu shots is lower than any other healthcare group in 3 different studies. Many times hospitals will mandate that their employees receive a flu shot, and if they do not comply, in years past they would make them wear a mask during flu season. Some hospitals recently will not allow those individuals to work in the hospital at all. Flu shots are not currently mandated in EMS, but that may be something that we see change in the coming years. Department-wide flu shot participation. I have numbers here for 2012, 13, and 14. So the total overall number of flu shots in 2012, we had 85 individuals. 2013, we had 86. Last year, we had a larger response. We had 102 individuals who received flu shots. Of those 102, 13 of them were non-employees or non-volunteers. So last year I gave you a dislike for the number of individuals who received flu shots. This year we get an indifferent because numbers are better. You guys are doing a better job. However, when we look at a department that is 600 to 800 people with volunteer and career included, 100 people is not a big participation on our part. So something to keep in mind for next year. There are different choices for flu vaccines. Many people will say, I can't get the flu vaccine because I'm allergic to eggs, or I have allergies to latex, or different things that come up. But there are 5 different types of flu shots now that offer a different variety. There is a website called flushot.healthmap.org, and if you log on to that, it will show you places in your area that offer flu vaccines. The first type is the standard vaccine, the trivalent one. It has 3 different strains in it. This is the one that is grown in eggs, so if you are allergic to eggs, you do not want this flu shot. This one is approved for people 18 years of age and older. The 3 strains in it, it has 2 influenza A's and 1 influenza B in it. The one for the upcoming season has an H1N1 from California, an H3N2 from Switzerland, and the third one, the influenza B strain, I will let you read the name there. It is from Thailand. I'm not going to pronounce where it's from because I'm probably going to get myself in a lot of trouble. The second option is a quadrivalent flu mist or injection. Quadrivalent means it protects you against 4 different flu strains. This one is not approved for kids less than 6 years of age because this one is live. It has 2 influenza A's and 2 influenza B's. So it has the same as what the flu shot has, and then it has another B in it that I'm not going to attempt that one either because that name looks pretty crazy. The third one, a high-dose trivalent shot. This has 3 strains in it as well. This one is for people 65 years and older, and this has 4 times the amount of the antigen that's in a regular flu shot, because it has been shown that people over the age of 65 generally require more antigen on board in order to get more of a response from the flu shot. The fourth kind is a cell-based flu vaccine. This one is manufactured in animal cells rather than being manufactured in eggs. So if you have an allergy to eggs, this one is the way to go. This is for people 18 years of age and older. There are some advantages to this as well, because in the event of a pandemic or a large outbreak, there's the potential for a faster startup of vaccine manufacturing because you're not reliant on a supply of eggs. The last one is a recombinant trivalent egg-free shot. So this one has 3 different strains in it as well. Its name is Flublok. It's FDA approved for people between the ages of 18 and 49. There is no influenza virus or chicken eggs used in the manufacturing process. There's no antibiotics. There is no mercury used in the manufacturing. So if you are allergic to thimerosal as well, there is none of that in this vaccine. It does have a similar manufacturing process to other vaccines, but it has a shorter shelf life. Its expiration date is about 16 weeks past its production date. This one also has a potential for a faster startup in the event of a pandemic. So people who have several different allergies or allergies to the big things like eggs, thimerosal, mercury, and antibiotics, Flublok is the way to go. There's a new antibody that's been discovered in recent years called CH65. This antibody is able to recognize several different strains of flu. There were 36 strains of flu that were isolated and tested. These were from 1988 and 2007. Of the 36 strains that were tested, CH65 was able to neutralize 30 of them. So there were only 6 of the 36 that this wasn't able to neutralize. One of the strains that it did neutralize was the 2009 H1N1 pandemic strain. This is very promising because this could evolve into a longer lasting vaccine that will protect against several different strains of influenza. For flu season, if you have a patient who you believe has the seasonal flu, we are going to utilize droplet precautions. A surgical mask on you and or the patient is appropriate. Now we're going to get into vaccines. The recommended immunizations and vaccines are listed below: hepatitis B, 1 booster of Tdap, chickenpox, MMR, flu vaccine, and TB testing. 2 main reasons for the recommended immunizations are because there are some immunizations that require boosters as adults, and there are so many unvaccinated children and immigrants in our country now that we are seeing some big diseases come back that we haven't seen in decades due to the large number of unvaccinated people. I included a table here for the vaccines that they recommend and information on why they recommend. So if you'd like to, go ahead and pause the presentation and you can read all of the detailed information here. I also gave you a link at the bottom that tells you where to go on the CDC website to get information on this. Updated information about our Tdap shot. Tdap is the adult version. The child version is DTaP. It protects against the same diseases, but its dosing is a little bit different. Tdap, the adult version, CDC does recommend a single dose booster shot for adults between 19 and 64 years of age. In individuals who have completed the recommended childhood vaccine, the single booster is sufficient. This can be given regardless of the last time that the vaccine was given. And boosters are recommended for healthcare providers involved in the care of children, as well as parents, grandparents, child care workers, and anyone else who works with small children. Moving on to the varicella vaccine. The varicella vaccine is the one for chickenpox. So if you have no documented immunity, it's just recommended to go ahead and get the vaccine. There's no need to draw a titer. If there's no documentation of immunity, just go ahead and give the vaccine because it's financially less expensive. Immunity for varicella is based on documented age-appropriate vaccination, lab evidence of immunity, or confirmation of the disease. Birth in the United States before 1980 is listed here as well, but this is not adequate evidence of immunity for healthcare workers, pregnant women, or anyone with a weakened immune system to say they were born before 1980, so we're going to consider them immune. Immunity is also based on diagnosis or verification of a history of chickenpox or shingles by a healthcare provider. The shingles vaccine is listed here. It is a one-time vaccine. There is no maximum age for receiving the vaccine, but it is recommended for people over 60 years of age. It's not recommended to treat active shingles. Moving to outbreaks, we have three big ones that we're going to talk about this year, and we're going to talk about the one that you have heard so much already, which is Ebola. It was previously known as Ebola hemorrhagic fever. It is a rare disease, but it can be deadly, especially when we're looking at third world countries. It is caused by the Ebola virus strain, and it can cause disease in humans and non-human primates, such as different classifications of monkeys. It's first discovered in 1976 near the Ebola River. Routes of transmission are listed here. First is blood or body fluids of someone who is infected with or who has died from Ebola, and some of them are listed below. Also from objects contaminated by body fluids from infected people or people who have died from Ebola. In African countries especially, infected fruit bats or primates such as monkeys and apes. Ebola virus has also been found in the semen of men who have recovered from Ebola, and it is possible that they can spread through sexual contact. So the CDC recommends that you avoid contact until further information is known. The highest risk of transmission is in family and friends who are in close contact with Ebola patients. This is due to the possibility of coming in contact with infected blood or body fluids. In the healthcare setting, during times of an outbreak, Ebola can spread quickly under certain conditions. These conditions include if healthcare providers don't wear appropriate PPE or do not remove it appropriately, and if medical equipment is shared among patients without being cleaned. Precautions to take as recommended by the CDC is to have dedicated equipment, preferably disposable equipment, in the patient's room. Make sure that you are properly cleaning and disinfecting equipment used on the patients. Properly dispose of items such as needles and syringes. And if equipment is not disposable, have it sterilized if possible before using it again. Ebola has not been found to spread through water, air, in general by food, and there is no evidence that insects or mosquitoes transmit the Ebola virus. In Africa, Ebola can be spread in other ways, such as handling bush meat, which is wild animals hunted for food, contact with infected bats, and through species of animals that have been known to contract and spread the Ebola virus, such as bats, monkeys, apes, and gorillas. According to the CDC, the 2014 Ebola epidemic is the largest that we've seen in history. It has affected multiple West African countries and other countries throughout the world, including the United States. We had 2 imported cases, one of which died, and 2 locally acquired cases in healthcare workers, both of which survived. Signs and symptoms of Ebola are listed below. They can appear anywhere between 2 and 21 days after being exposed to Ebola, but the average is about 8 to 10 days. Recovery from Ebola does depend on good supportive clinical care and the patient's immune system response. Ebola survivors do develop antibodies that last for at least 10 years. Ebola prevention for healthcare providers. Currently, there is no FDA-approved vaccine for Ebola. The CDC recommends that you use proper hand hygiene, such as washing your hands with soap and water or using an alcohol-based hand sanitizer. Wear appropriate PPE when dealing with patients with suspected or confirmed Ebola. Use proper infection control and decontamination or sterilization measures. Isolate the Ebola patient from other patients. Avoid direct contact of the bodies of people who have died from Ebola, and make sure you are wearing PPE if you do need to handle these bodies. Notify health officials if you come in contact with body fluids or blood of a person who is infected with Ebola. The Ebola virus can enter the body through unprotected mucous membranes or through broken skin. A travel history is important when looking at Ebola. We want to ask if patients have been to Africa or areas with known or suspected Ebola patients, especially if they are showing signs and symptoms of Ebola. A fever is listed here, and we want to make sure that if they are showing signs and symptoms that we want to take appropriate precautions, which are standard, droplet, and contact precautions. Airports are taking special precautions, especially in countries where patients are known to have Ebola. They are conducting health screenings in the airports where they will check passengers' temperatures, assess for signs and symptoms of Ebola, and ask general questions about their health and Ebola exposure history. Travelers also receive a care kit, which is displayed below, and it includes things such as a digital thermometer, a cell phone, and information about contacting appropriate personnel if signs and symptoms of Ebola do occur. Travelers from countries with Ebola can only fly into 5 airports in the country. The United States has this in place so that we are able to track where they are coming from and where they have headed to, because they have only been able to come into one of 5 airports. Those airports are New York's JFK, Newark, Washington Dulles, Chicago O'Hare, and Atlanta. Also included on this slide is information based on their risk of exposure and whether or not passengers are allowed to travel. For Ebola and EMS, I have included a PDF in your assignment on Target Solutions that you will be able to print out that has this information on it. It is an algorithm. It starts with dispatch and it goes through your EMS call. The dispatchers will inquire about travel and direct exposure history within the previous 21 days. They will ask about signs and symptoms. They will provide instructions to the patient and/or EMS providers. This will help EMS get information before coming on the call, knowing what type of PPE needs to be worn. The medical director may be involved in this as well and may consider additional questions or actions specific to the local area or region. Once this information is gained, then EMS will be dispatched. Prior to EMS arriving on scene, there are some considerations for infection control and PPE. These are listed here. Please be sure that you read over these thoroughly in the PDF that you are printing, or you can pause the presentation now to read them. Some key things listed here are making sure that you have the least amount of essential personnel coming in contact with the patient that you suspect has Ebola. They must have proper PPE on. They also say for the initial screening to stay about 3 feet away from the patient, and they do say that you need to have a dedicated driver who has not come in contact with the patient. Anyone that has come in contact with the patient needs to be in the back of the ambulance for transport, so if needed, you can request an additional resource so that you do have a dedicated driver. For occupational exposure to someone who has suspected Ebola, there are steps listed here, such as if an EMS provider has come in contact with blood, body fluids, secretions, or excretions from the patient, they should stop working immediately and begin washing affected skin surfaces with a cleansing or antiseptic solution, and mucous membranes should be irrigated with large amounts of water or eye wash solution per protocol. Information is also listed here, such as putting all of the wipes and solution in a biohazard bag, placing all waste in biohazard bag, and notifying your chain of command as far as the occupational exposure. Once EMS arrives on scene, there are steps here as well, such as, did you get information from dispatch saying that the patient does meet Ebola criteria? So step 1, considering the appropriate PPE in the EMS setting for a person with suspected Ebola. Step 2, inquire about their travel history and direct exposure history within the previous 21 days. Step 3, assess for signs and symptoms. Step 4, isolate the patient immediately and revisit step 1 from EMS arrival on scene. In this step, they do mention that interventions such as intubation, suctioning, or CPR definitely will need the use of PPE when caring for these patients. Step 5, avoid unnecessary direct contact while managing the patient, and then prepare to transfer to the appropriate facility. Make sure you are informing the hospital that you are transporting the patient to as soon as possible to let them know that you have a patient with suspected Ebola. Transport to a healthcare facility. In step 6, you are transporting the patient according to the agency and local protocol. Step 7, follow infection control principles during the transport to the hospital. And step 8, at the hospital, after you transfer patient care, you must have a supervised or observed removal of PPE. The PPE removal process does need to be a supervised process. It needs to be performed in a designated location, and it needs to be done in the presence of a trained observer in order to prevent self-contamination or other exposure to Ebola virus. If possible, a shower should be provided for EMS providers, as well as an area to change into clean clothing. The PPE removal procedure is a high-risk process. The CDC requires a trained individual to be present to view the removal of PPE. They also require a designated PPE removal area. PPE must be removed slowly, deliberately, and in the correct sequence in order to reduce the risk of exposure. This does require training and routine practice. Double gloving is appropriate during patient care, but there is no need to double layer other PPE such as a gown because it can hinder performance and movement. Hospital recommendations are listed here as well, such as designated PPE removal area must have supplies to disinfect any reusable PPE. They must have areas for proper hand hygiene and a place to sit to remove shoe covers. This area must also be cleaned and disinfected frequently. There are also recommendations such as considering making showers available for use for EMS providers after the PPE has been removed. Step 9 is to decontaminate and disinfect the vehicle and equipment while wearing appropriate clean PPE. It also addresses the disposal of waste. Please be sure that you are reading this information thoroughly and carefully. Pause the presentation now if you would like to read it on screen, and please be sure to print this PDF. Additional information for Ebola and EMS. Putting on personal protective equipment. This also will be available as a printable PDF for you, so please be sure to print that out. This table effectively shows you how to put on a gown properly, a mask or respirator, goggles or a face shield, and gloves. Information for removing of PPE. This is also a PDF for you to print out after the PowerPoint, so please be sure that you do. It shows you how to remove the PPE, such as the steps for removing gloves, goggles or a face shield, a gown, and your mask or respirator. The next outbreak that we're going to talk about is the measles outbreak. Measles is a highly contagious virus rash illness. Incubation period is anywhere from 1 to 2 weeks. Symptoms include cough, high fever, runny nose, red, watery eyes. 2 to 3 days after symptoms appear, there can be white spots that appear on the inside of the mouth, and 3 to 5 days after symptoms begin, there can be a rash with flat red spots or small raised bumps on the face at the hairline and spread down the neck, trunk, legs, arms, and feet. Fever can spike over 104 degrees when the rash appears. This virus lives in the nose and throat, mucus of infected people. Routes of transmission are respiratory, droplet, and airborne. Measles can spread to other people from 4 days before through 4 days after the rash appears. It only occurs in humans. It does not occur in other animals. Common complications include diarrhea and ear infections that can result in hearing loss. Severe complications include pneumonia, encephalitis or swelling of the brain, and death. Measles is still a common issue in some parts of the world. Countries that still face measles on a regular basis include Europe, Asia, the Pacific, and Africa. In the United States, the MMR vaccine is a part of routine childhood vaccines. Measles is covered in this. The biggest cause for cases in the U.S. are infected travelers that bring this into the country. Once measles enters the United States, it can spread rapidly, and it generally spreads among unvaccinated people. Again, in the United States, our largest groups of unvaccinated people include unvaccinated children and immigrants. The United States had 23 different outbreaks of measles in 2014. One of the largest outbreaks included 383 cases, most of them which occurred primarily in Amish communities in Ohio, where citizens were not vaccinated. Many cases from 2014 were linked to the measles cases brought into the U.S. from the Philippines. From January 1, 2015 to May 1, 2015, there have been 5 reported outbreaks of measles and 169 reported cases of measles in the United States. 20 different states were involved in this multi-state outbreak. The outbreak was linked to an amusement park in California. This likely began with an infected traveler who visited the park while still infectious. There is no definite source identified. This strain of measles is linked to the virus that caused the 2014 large outbreak in the Philippines. The majority of those affected by measles were not vaccinated. This is a map showing states that had confirmed measles cases from January 1st to May 1st, 2015. Measles vaccines in times of an outbreak. For healthcare professionals, they need to have documented evidence of immunity against measles according to the recommendations of the Advisory Committee on Immunization Practices. Presumptive evidence of immunity to measles for individuals who work in healthcare facilities include written documentation of vaccination with 2 doses of live measles vaccine administered at least 28 days apart, laboratory evidence of immunity, laboratory confirmation of disease, or birth before 1957. If you have documented evidence of the live MMR vaccine that was 2 doses given at least 28 days apart, you do not need to take any other precautions. You are considered immune. Please verify your medical records. Information on the MMR vaccine. People who received the MMR between 1963 and 1967 should be revaccinated with the live vaccine. They received a dead virus vaccine and it was ineffective. Individuals who received this vaccine should not have a titer drawn because it's not necessary. Just revaccinate with the 2-dose MMR vaccine. If a person's measles status is unknown, there is no need to draw a titer, just revaccinate. Mumps is another outbreak that we saw in 2014. This is a contagious disease caused by the mumps virus. Transmission is by direct contact with respiratory secretions, face-to-face contact, or greater than 5 minutes in the same room as an infected person. Signs and symptoms usually show up 12 to 26 days following the exposure and include fever, headache, muscle aches, swelling salivary glands, and orchitis. Prevention for this is the MMR vaccine. Again, it is a live vaccine not to be given to pregnant women. A post-exposure vaccine is not effective in treating this. Work restriction is essential for 12 to 26 days following the exposure event. The 2014 mumps outbreak, there was 1,151 reported cases of mumps in the United States. Since November of 2014, the CDC received reported cases from mumps from professional hockey teams. They are currently conducting public health investigations. Multi-drug resistant organisms. For multi-drug resistant organisms, make sure you are using a chlorine-based cleaning agent when dealing with C. diff and norovirus. Hand washing with soap and warm water is still necessary after caring for patients with C. diff, and alcohol-based products are not effective. CRE is another multi-drug resistant organism. This has high levels of resistance to antibiotics, and it generally does not infect healthy people. Infections are difficult to treat, and it does have a high mortality rate. Contact precautions are necessary when caring for these patients, as well as getting a good history, such as their health history. Do they have sepsis? Do they have indwelling catheters? And a travel history, such as have they been in an overseas hospital within the last 6 months. Prevention. Surgical masks are appropriate to place on patients with respiratory conditions. If the patients cannot tolerate the surgical masks, place one on yourself as protection. Make sure that you have good airflow in the vehicle. Proper hand washing is still the best way to prevent the spread of disease. Make sure that you get an effective travel history as well on your patients. Proper hand hygiene. The CDC recommends indications for using proper hand hygiene as listed below. If your hands are visibly soiled, use soap and water. If they are not visibly soiled, an alcohol-based hand rub is appropriate. Make sure you wash your hands before direct contact with patients, after contact with patients' intact skin, after contact with body fluids, mucous membranes, excretions, and wound dressings. Moving from a contaminated body site to a clean body site during patient care, contact with inanimate objects, after removing gloves, before eating, and after using the restroom. Antimicrobial impregnated wipes can be considered as an alternative to washing hands with non-antimicrobial soap. They are not as effective as alcohol-based hand rubs. They are not as effective as washing hands with antimicrobial soap and water, and they are not a substitute for using antimicrobial soap or alcohol-based hand rubs. If exposed to conditions caused by spores, wash hands with antimicrobial soap and water or non-antimicrobial soap and water. Alcohols, chlorhexidines, and other antiseptic agents have poor activity against spores. Triclosan's lack of potent activity against gram-negative bacilli has resulted in occasional reports of contamination. Agents that contain triclosan are not recommended in healthcare settings. When washing your hands, rub hands vigorously together for at least 15 seconds. Avoid using hot water because this can increase your risk of contact dermatitis. Warm water is appropriate. Multiple-use cloth towels are not recommended. Dry hands with disposable towels. Antimicrobial soaps are recommended instead of antibacterial soaps. Also, make sure you have no artificial nails, as they can harbor bacteria. All sharps containers for Horry County Fire Rescue are to be disposed of at Grand Strand Regional Medical Center. Put sharps containers inside the door of the tan shipping container. This is located on the loading dock side of the hospital. Seal the container with medical tape and write the number listed here and HCFR on the tape. Make sure you're washing your hands as soon as you can after a call. Make sure you are not just using hand wipes or hand sanitizers. Make sure you are using proper decontamination techniques for your apparatus, for your equipment such as stethoscopes, blood pressure cuffs, backboards, pulse ox, and glucometers. Make sure you are also appropriately decontaminating the inside of the cab of the medic unit. Make sure items are labeled appropriately as well. As a reminder, hypochlorite solution is a 1 to 100 mix, 1 part bleach to 100 parts water. It must have a piece of tape on it stating 1% hypochlorite solution, the date it was mixed, the name of the person who mixed it. There must also be an SDS sticker for the hypochlorite solution on the bottle. This bottle must be refilled every day. Also note that there is no abbreviation for hypochlorite solution. The sticker on the bottle must be labeled as shown here. The chemical name, Austin's Bleach. The manufacturer's name, James Austin Company. Address, 115 Downeyville Road, Mars, Pennsylvania, 16046. Emergency phone number, 1-800-228-5635, extension 234. Changes to post-exposure reporting. When an exposure occurs, call the exposure control line, which is 843-915-7063. Most of the time, Captain Tony Flaherty will be handling post-exposures. He will contact the infection control nurse and then respond to the hospital where you are transporting your patient for the completion of the Workman's Comp S&E report. Your post-exposure treatment will be dependent on what you were exposed to and what the CDC recommends. The only time Captain Flaherty will not be handling post-exposure reporting is if he is out of town. When he is out of town, Captain Tim Prince will be handling the post-exposure reporting. He can be reached at the same line, 843-915-7063. Workplace restrictions. Do not work when you are sick, potentially contagious, or definitely contagious. Decisions on work restrictions are made based on the mode of transmission of the disease or illness and the epidemiology of the disease. I have included a table of work restriction guidelines from the CDC. It lists the disease or problem, the work restriction, the duration, and the category. Feel free to pause at any point during these slides to read and gain more information. I have also listed a website at the bottom of the page that shows where you can access this information and get additional information on these conditions and work restrictions. This is the title of the article shown here as well, so you are sure you are at the correct site. For questions regarding this information, please contact Captain Tony Flaherty at 843-446-6610. Please make sure you do speak to him and not just leave a message on his voicemail. For questions regarding this bloodborne pathogens update, you do need to speak to him in person or on the phone. That number again is 843-446-6610. Also, this assignment must be completed no later than Thursday, June 25th, 2015 at 5 p.m.